Good evening and welcome to all. This is Ankana, the assigned moderator from IJCP Group. I welcome all the delegates across the country in today's session. We are fortunate enough to get supported by the doctors. Thank you, all the doctors, for taking out time to join us today in the session, The Silent Struggle, Unraveling the Challenges of Infertility and Empowering Women. In celebration of International Women's Day, we invite you to thought-provoking session featuring leading experts in reproductive health. Infertility is a deeply personal yet widespread health challenge affecting millions of women globally. Despite its prevalence, it often remains a silent struggle, one that carries emotional, medical, and societal complexities. Together, let's break the silence, foster awareness, and empower women with knowledge and support. Hence, without any further delay, I'm taking this opportunity to welcome today's speaker, moderator, doctor, none other than our very well-known keynote speaker, Dr. Jyoti Malik ma'am. We also have two more keynote doctors in today's session as our panelists, Dr. Minu Handa ma'am and Dr. Lakshmi Goel ma'am. Now, I would like to hand over the session to Dr. Jyoti Malik ma'am. Ma'am, kindly proceed with the discussion. Over to you.
Yeah, thank you so much. Thank you, IJCP, Ankana, and the complete team behind this platform. And it is always a pleasure to be here on this platform because it is being watched by so many viewers and coming from different sort of modes, different platforms. And today being the Women's Day, it makes this program much more special because as the chairperson of ISAR Haryana, ISAR is Indian Society of Assisted Reproduction, and we are the Haryana chapter where I'm the chairperson, and I have my team here with me today. We have the secretary of the Haryana chapter, Dr. Meenu Handa. She is practicing infertility specialist at Cloud9 in Gurugram. And then we have our treasurer, Dr. Lakshmi Goel, who also is practicing in Cloud9, but in Faridabad. So we, the infertility specialist, and I practice in Bahadurgarh, which is a town which is NCR near Delhi. And we all are fertility specialists. And today we thought of taking a topic of unraveling the challenges of infertility and empowering women, because as Ankana said, that infertility is being faced by many couples. It is not only the women who suffer from it. It is multiple. It has multifactorial reasons why infertility is there. And by the time we have now Dr. Lakshmi has already joined us, we would be, once Dr. Meenu joins, we will again continue the same. But to start with, I'll go to Dr. Lakshmi and I would make a statement like, since infertility, we have seen it. We have in our practice, we have seen that the infertility patients are increasing. So, number one, how do you define infertility? What are the causes of infertility, and are the treatments simple, or is it only the IVF that we always have to look forward to? Because as such, infertility as such, we will talk the various challenges behind it. But to start with, to make our audiences, our viewers, much more comfortable with what we are talking, that is what I would like you to answer.
Okay. Yeah, first of all, thank you, Dr. Jyoti. Thank you, IJCP, for this wonderful session, and also a very happy Women's Day to all the women out there who are listening to this session. So, it's a very important session. I think it's not much talked about, and we've taken this very important point, of very important, I think, something which has a stigma behind it. This disease, or what, actually it is not a disease, and it has a lot of stigma behind it, and it is, also we have so much to talk about empowering women. If we talk about infertility, it sort of takes a woman back. So I think we will discuss everything about infertility today. So first of all, as Dr. Jyoti asked about infertility, so when do we call a patient of a couple infertile? Suppose a couple has been trying to conceive since 1 year without any protection, then we label them as an infertile couple, and then we tell them to seek for help from doctor. So you'll be surprised to know that up to 50% of the times the cause can be due to male related or male partner related. And so many times in the society we hear that a female is always blamed when a couple is infertile, but it is very very important for us, for everyone to know in the society, that 50% of the times male is responsible for this problem. So males should also be evaluated equally as female is evaluated. So if we see the causes of of infertile couple, for the reason of infertility, we see that the female can have problems related to uterus, related to tubes, related to ovaries, the eggs, as well as the male, which has problems related to semen factors, the low sperm count, the motility issues, which can all be there in the male partner. So, whenever a couple arrives, we tell them to get a proper evaluation for both of them. So, yeah.
So sometimes I think, Dr. Lakshmi, I think there could be sometimes no reason also when we call it unexplained.
Yes.
So how common is that, and why is it happening? Or is it our lifestyle, or
Yes.
the changes that are occurring in our sleeping pattern or something? What
Yes,
exactly?
yes. Nowadays, I think we see a lot of couples with, like, there's no reason. No, we evaluate a couple, do all the tests, do an ultrasound, do a male partner test. All the tests are normal. So it's called unexplained infertility, and it's quite commonly seen thing nowadays. And what we see as an infertility specialist, that the because of the work stress, work pressure, late marriages, because of the female being, of course females want to be career oriented, they want to plan their pregnancy a little later in life, and also because of the environmental issues, pesticides, the toxins in the environment, because of the sleeping disorders, sleep pattern changes, we see a lot of hormonal, a lot of stress, and sometimes the sexual that drive, or the the timings for the couple doesn't match. And most of the time they come to us that we are not able to match our timings for intercourse when you tell us. So that can be one of that all can be the reasons of infertility that we see nowadays.
Do you think now people have become more open talking about infertility when compared to when maybe 10 years down the line, when people were not even talking, they were not taking treatment, or even if they were taking treatment, they were keeping it very secretive. And as you rightly said, initially said, that there is a stigma related to infertility. So people don't want to talk about it. They want to be, and if they are not talking and they are suffering from this, so what all could be what is the reason behind it, that why it is a stigma? Because as you said, it is not only the woman which is responsible for it, it is the male factor also, and equally 50% could be the combined factors. So it is and every time female is being blamed. If if she cannot bear children, it is always not the male partner but the female partner. But do you think now people have become open, they have started talking, they have started taking treatment, and in fact if they are taking ART treatment, they also would are open about it and let people know about it? Initially they even used to keep it a secret even from
Yes.
their parents.
Right. Yes.
So
So we see mixed population, like mixed type of patients. Some patients are very open to it, they're fine with it, and they talk about it openly. But then we have other type of females who are little, they are subdued, maybe they have a family fear, and then they don't want us to reveal it to their family members and to their parents also. So we still like, we have we have so much of technology everywhere. We have iPhones, iPads, Android, robots we are talking about, but still here, I still think that people are still little conservative about this. They don't want to talk so openly as in other fields we see. They're still little conservative in their
Yeah.
yeah.
So, do you think there, I mean, it has a strong emotional challenge is a factor which is always associated with infertility. So,
Yes.
what are the emotional challenges that these women face because of infertility? What all can happen?
Yes, so actually, it's a very, very important point that you've brought in. There is so much of need of counseling to these females, especially to the couple, to the female, because besides the medical challenges, the treatment part, they also have a lot of emotional, psychological disturbance in their mind, and and for which they constantly need support, and they constantly need counseling. So it is, we as an infertility specialist, we always take time, we always try to take time out to counsel the patient, but still that that level is still lacking in our society, that counseling part. And apart from us, the family, the husband, the parents also would be, it is really helpful if they counsel if they are together in the treatment, if they help her in us emotional and psychologically, they help her in the treatment, then they're
Yeah.
able to, yeah,
Yes.
manage it little in a little better way.
Yeah. So we have a lot of stress related to infertility. We have a
Right.
lot of depression. Some women can even go into depression. They can go into isolation. They don't want to even go out in the party or
Mm.
in any social meetings, because they feel that they will be looked upon little differently,
Right.
or they cannot cope up with that social pressure also. So I think as the Fertility Act, as the ART Act also has specifically in ART level 2 clinics, they said that
Right.
it should always have a counselor. So
Right.
the counselor could be anybody. It is, but basically it is more of a hand holding thing that we need to do with these women, so that we can talk to them, we can allay their anxiety, their stress, their depression, their isolation, and sometimes they have even relationship strains are there.
Yes.
Suppose if the woman is responsible, then sometimes she is even told that she'll be divorced if she does not produce a baby. And sometimes if the male is responsible, she can't even speak because she feels the ego will be his ego will be hurt. So
Right.
there are many relationship strains. In fact, when the couple should sort out or should fight with this issue together and not leave the other person alone in such situations. And
Right.
I think a stress management part should be there, where you can also at least be as a stress management busters, yoga, meditation, group. You can have groups, I think, peer groups, the groups where the such patients, when they come together, they talk to each other, and then they exchange phones, and then
Right.
they can make a group and they can talk together, so that, and once somebody gets the test comes positive and somebody conceives, then the others also have a hope ki, oh,
Yes.
she could conceive, so we also would conceive.
Yeah,
So
I
I
think
think
that's a
those
very good idea. Yes, I think there must be groups, but of course
groups
we
in,
can still promote them in a better way.
yeah. So,
Mm.
and also there are social and cultural issues related to the infertility, and I think talking about it openly on platforms like this, on social medias, that it is one of the something, if you have a hypertension, you might have a diabetes, you might have another issue like a infertility. And since now the science has improved so much, what do you say about the infertility treatment? How many would conceive on their own? How many would need further? What all are the different armamentariums of treatment that we have for infertility?
Right. So we have so many newer things. We have so many treatment options for these couples, starting from medicines. So normally we give some ovulation induction medicines, and then we do some ultrasound for the couple, for the female, to see how their follicles are growing. And then we can tell her to take a trigger injection that will rupture her follicle, and then tell them to have a time intercourse. So that is one treatment option by which I think almost 40 to 50% of the couples will conceive. That's a very simple treatment, and that might take 2 to 3 months for them to conceive. But then if it doesn't work, then we have other treatment options as well, like intrauterine insemination, that's called IUI. And in that particular treatment, we give female few medicines for follicle monitor, and then we do follicle monitoring with the help of ultrasound. And once a follicle ruptures, we take the semen from the husband, wash it in the lab, and then once we have the washed semen, put it inside the uterus of the female. It's a very simple, gentle procedure. There's no pain involved in it. And like, if the female is not being able to conceive in the natural try, then they can opt for IUI. Its success rates is around 25 to 30%, and it's a very simple procedure. If normally we do 2 to 3 cycles of IUI, if that doesn't work, then we can tell them to go for IVF, that is in vitro fertilization. So IVF is, something like, it's still people are little, taken aback when we tell them IVF. Still, we see change, a lot of change in the society from back, like before, when we used to say IVF, people used to say, no, no, ma'am, that we can't go for IVF. But now they are more receptive to this, because in this, first of all, I want to clarify that the egg and the sperm both are of their own couples. Like, we don't, use someone else's eggs or someone else's sperms. So that egg will be of female, the sperms will be of male. In this particular treatment, what we do is we give injections to the female starting from day 2 of the periods, and we give them for 10 days so as to stimulate her follicles, take out the eggs with the help of ultrasound. On the same day, we take the sperms from the males and then fertilize them outside in the lab. We have the embryo outside in the lab. Once the embryo is formed, we place that embryo inside the uterus of the female. It's a very, very, very gentle procedure when we place inside the embryo inside the uterus. And normally, this, apart from injections, this treatment does not have so much of pain. There is no cut involved on the body. There is no incision involved on the body. And overall, the success rate is around 50 to 60%, which is a good, like, it is a very good treatment. If the couple is not being able to conceive naturally, then we opt them to go for, and tell them to go for IVF treatment.
Yeah, so very rightly said, Dr. Lakshmi, that okay, so many patients, even without any aid, without any IUI, without any IVF, do conceive just by a little monitoring, that is just by medicines, by ovulation induction. And there are medicines that we have very simple to use and very easy and very safe ovulogens, which we use. And by ultrasound monitoring, we time that means the egg has formed, and then we can, that means they can try. So and in fact, the PCOS I would like to touch upon here, because PCOS, so many girls and women are coming with PCOS, which is polycystic ovarian syndrome, which is a hormonal imbalance, and the ovulation does not occur. Their cycles are anovulatory, and just by correcting their ovulation, most of them do conceive. And PCOS, most actually, there are obese PCOS and lean also, but obese by lifestyle management, by their weight reduction, by the diet plans, and by their I think just by these simple procedures, by these simple behavioral procedures, they can get ovulatory cycles and they can conceive. Some of them who do not conceive, actually some of the resistant pieces are there who would further need such IUIs, and at least 3 to 4 IUI is what that you suggest that these days we go in for. And once IUI does not work, then depending on what the indication is, or if I forgot to ask that if the woman is older, so should we still wait or should we hurry up? Because these days, the career-oriented women, normally they marry very late, they marry around 30 plus, and they again wait for 3-4 years. And once they come to us, they are nearly 34, 35. And what are the problems that can occur if they conceive late? And what are the issues in conceiving? If we can briefly tell our viewers.
So once the woman is 35 or plus, we tell them, like, if they have been trying for 6 months and they have not been able to conceive, we tell them to go in for the treatment. And because the biological clock is ticking, every day, every year, the females, the eggs are deteriorating, and the ovarian reserve is getting lower. So we don't take too much of time in every step. We give some medicines, and then tell them to go for natural try for 1 to 2 cycles. If they don't conceive, then go for IUI, maybe 1 or 2 cycles. But if they have any problem before, like if we see that the male factor, there is some kind of male problem also, or some kind of tubal factor is there, if the tubes are not open, tubes are not patent, or if she has a lot of cysts, or there's something called endometriosis. If she has endometriosis, we tell them that to go directly for IVF, not to wait, because with increasing age, the result of IVF also goes down. So at the age of 35 to 37, the results are almost around 50. But after 37, it goes down, and then after 40, it starts goes down at a very steep trend. So that is why we don't wait too much once the female is aging.
Is there any way of empowering of women by doing a oocyte cryopreservation?
Yeah, I think that's a very important topic that Dr. Jyoti has come up. So, because we know that the biological clock is ticking. If the female wants to, invest her time in her career, so she wants her family, planning to be delayed. But because of this social stigma, because of a fear that with age she will not be able to conceive later on, there is a very important tool by which we can empower female, that is the oocyte freezing. What we can do in oocyte freezing is we will stimulate the female for 10 days with injection, the gonadotropin injections. We can take out her eggs and we can cryopreserve those oocytes. And once cryopreserved, we can use them for years. After maybe 2 years, 3 years, 4 years, 5 years, whenever she wants to get pregnant, then we can use those oocytes that were frozen way back. So in that way, we can use those oocytes which are of younger age and which are healthier when she has grown to maybe 40 above, when her oocytes, the eggs are not of that good quality. So I think that's a very, very important tool that all career oriented females can think of once if they want to delay their pregnancy.
Okay. So I think it is always a good idea if you are a career oriented and you've not found your right partner and you are not ready for the marriage as yet or whatever, then maybe we can, earlier the better. If we freeze our oocytes at a younger age, at around 30, 31, 32, we will get more oocytes. Plus, we will get better oocyte quality
Right.
rather than doing it at 35, 36 years of age when our oocyte yield is less, the oocyte quality is less, our AMH has gone down, and our eggs have become older. So these eggs, when they produce embryo, these embryos also will not be healthy. So embryo means a baby that will not be healthy because of the chromosomal changes that are occurring in our body with age. So with the age, so our embryo will not be a healthy or a euploid embryo. The risk of aneuploidy is increased once the oocyte ages increase, and therefore the risk of other Down syndromes and other things increases, the risk of pregnancy complications increases, the risk of diabetes during pregnancy, gestational hypertension, risk of miscarriages, preterm labors, instrumental deliveries, cesareans, and prematurities, IUGR, growth restrictions. These are other pregnancy complications that do occur with the increase in age that happens. So it is always better to have younger oocytes than the older oocytes, because even if we have done oocyte freezing at older age, those embryos may not implant.
Right.
Also. So we might not have that sort of pregnancy rates if it is done that way.
Right.
So another, I think, how we can take charge of ourselves by doing the lifestyle management. So I think that is one thing, and then we can we have another 5 minutes, and we'll because we are overshooting our time.
Yeah.
we'll-
So I think Dr. Jyoti is the best person to tell us about that, because she herself is too much into exercises, and I think that's a very, very important, and I think all females must take out time for themselves, for their lifestyle management, for exercises, for diet management, and at least for some kind of yoga or some kind of dance exercise. Any kind of physical activity is very, very important, because as we age, our as we age, we see that all the cells, they are aging. As similarly, our oocytes, they are aging. So when we have a healthy lifestyle, that effect on our oocytes on the body is little less. So we have a study in which when we compare Indian female with the Spanish female, we see that the Indian females' eggs are 6 years older than the Spanish females. That means what we have at 36, they would have at 42. So it is very important for us to understand that we must take care of ourselves, you know, by having a good, healthy lifestyle, by doing regular exercises, by adopting good dietary plan, so that we can take care of ourselves and of our eggs, of our fertility in a better way. So what do you think, Dr. Jyoti, about the lifestyle? You are the best person to tell us about that.
Yeah, exactly. See, lifestyle also includes not only exercise, but also many other things. Eating healthy, eating right,
Yeah.
eating at dividing your meals, having proper food which has less carbohydrate, low glycemic index foods. So those
Right.
are the foods one should prefer. One should have a high protein, low carbohydrate diet with a little fat, and it should be a diet which has mix of everything, all colors, white, orange, yellow, green, so that way we can have, our plate should be like a rainbow. It should have multiple colors. So we have the various fruits, we have vegetables, and we have the proteins as well, the egg white, or the milk, curd, then yogurt, this paneer and tofu and all. Cereals are very good. So, I mean, and if you're non-vegetarian also, it does not, I mean, it can be whatever you like. You have to eat healthy. So that also plays a very important role, the diet apart from the exercise. And when we are planning, so the smoking part and the alcohol also are two factors which should be taken care of, and they should not be, I mean, the smoking has a lot of harmful effect. In fact, a bit about male infertility. Why male infertility has increased is, I think, because of these lifestyle changes only, and because of because of environmental factors, because there is a lot of pollution there, and the laptops that we use, which we put on the lap, and that gives a lot of heating to the heating effect, which has effect on the low sperm, which causes low sperm count. So use of mobile phones, use of laptops, smoking one should avoid when you are planning. And, these days, both male boys and girls are equally into smoking and into alcohol. So if you, when you are planning a family, these are the two things that you should always refrain from. And not only a proper sleep pattern is also very important, because at night you have all those hormones being released, which are pro fertility. So those things we have to go back again, I think, past 30 years, when the things were simpler, when life was simpler, and we can go back into the fertility rate would then definitely improve.
Yes.
So we have this ART Act also, Dr. Lakshmi. So we have, what do you think? We have this, the oocyte donation. I would just like to ask about that. That so which cases would need a oocyte donation? I mean, when we've dealt with everything, and we have also seen that, okay, the patient, the lady is aging, her oocytes are not good, or the reserve is very poor. Is there another option left of the gamete donation? So gamete donation, I would like you to touch both on male and the female gamete, and what our law suggests, and how we have the ART banks, and let us know about that.
Right. So sometimes whenever like we go for tests of males and females, we see that the male doesn't have any sperm count or the zero sperms. That's called azoospermia. In that particular case, we can advise the couple the sperm donation, IUI with the help of sperm donation. That's called IUI with donor insemination. So for that, we have the government, the ART Act, which has come in 2022, has specified the criterias to the ART banks. So we have the sperm donation banks, which are government certified banks, and there are few criterias that they would take the sample from the donors, and then they will maintain the sample according to, there are few criterias for it. They will get the tests of HIV, hepatitis B, VDRL, and HCV. These tests have to be done, and then they will store the sample. And then, whenever the infertility doctors or the infertility clinics will ask for the sample, then they will specify what kind of sample they would need according to the color, complexion, the blood group. Then we can recruit the sample from these sperm banks. Similarly, we have the oocyte donation, the egg donation banks. So, some females would require oocyte donation, specifically the females in which we see that the ovarian reserve is very low. There is a very important test which we can talk about is AMH. We normally get this test done for all the females, and if we see that the reserve is very low, that is AMH is very low, less than, let's say, zero point 0.1, less than 0.2, then we offer the female the oocyte donation, because if they don't have eggs, then we can borrow the eggs from some other female, and we can use the husband's sperm, form the embryo, and that embryo will be transferred to the female's uterus. By this particular method, we can, the female can get pregnant, and the pregnancy chances are very good with oocyte donation. So it is completely legal, and the government has made some criterias. There are few criterias, because when we are doing oocyte donation, it comes through the ART bank, and these are government certified banks, And there are few criterias that donor has to be met before starting with the stimulation to the donors. That is, the donors should be married. The age of the donor should be less than 33, between 22 to 33, and then the donor should have a baby, at least one baby. We follow these, we see these criteria. Once the criteria are fulfilled, then we can stimulate that donor, and then we can take out her eggs. Oocyte pickup, the ovum pickup is done for the donor, and then we can use those eggs with, and then we can fertilize those eggs with the husband's sperm, form the embryo, and that embryo can be transferred in the female's uterus. So female should not, should not lose hope if her eggs are too less, or if she doesn't have eggs, or if she has attained menopause. Sometimes we see that nowadays there is little early menopause, premature menopause, or premature ovarian failures are lot of cases we see nowadays of premature ovarian failures. I don't know, post COVID, we have seen lot of changes in the body. Especially, we see that the reserve is getting lower, and the lot of ovarian premature ovarian failure is there. So these females can go for oocyte donation. Should not lose hope. By this particular method, they can get pregnant, and the chances are really good
Yeah.
with oocyte donation.
So this is another issue, the thing that we should not get worried, though it is always good to have your own genetic eggs. And there are multiple ways that we can do. We can do multiple IVFs, we can do embryo, make babies and
Yes.
pool them. So we can do embryo pooling, then we have multiple sort of other medical treatments that we give along to rejuvenate your ovaries. We can use PRP, we can use stem cells. So those are the things by which we can improve your oocyte reserve. And plus there are certain medicines, certain a little bit of testosterone addition and everything. So there are things, we go stepwise, and once the things do not work, then we have oocyte donation, which we take the oocyte donors from the banks. One donor can donate only once in her lifetime. She should be married, and her consent, she should have at least one living child, and her husband should consent that she can donate. And the person who is taking her eggs will then do sort of insurance for her. So any problem, anything, if in that one particular year, if anything happens, the oocyte donor also has an insurance. So it has become very safe for the donors as well, and also for the people who are in need of this. In fact, even for the male gametes also, if the male partner is not able to doesn't have a good count, and the other surgical things have been tried, and the last thing one can do is also take a semen donation from ART banks, which also male semen also once has the donor has can only donate once in lifetime, and these are all very tested samples. So I think we have discussed most of the things, and I know there are a lot of emotional challenges, there are a lot of medical challenges associated with it, the lifestyle and health challenges. Then the social and cultural challenges are there with the infertility, and the ethical and the moral dilemmas are there sometimes with whether the patient feels okay doing a third party donation or going in for surrogacy. So there are many challenges associated with infertility, and but there are ways to deal with them, and that is why I mean, one should feel that okay, one should feel empowered, because we have the treatment for it. The only thing is you should not lose hope. You should have the strength, and the couple as such should also be together, so that they can overcome this challenge together. And I'm sure on this Women's Day, all women who are listening are already feeling good, because this is our day, this is our day of empowerment, and just to make us remember and feel that we are equal. And this year's theme is empower every woman, equality, progress, and inclusion. So equality, we are already, the women today are equal. हम अपने मेल काउंटरपार्ट्स के साथ कंधे से कंधा लगा के चलते हैं, and we are progressing, and the inclusion needs to be there, that the women needs to be included in the all decision making processes, be it your family, be it at the workplace, be it the little society that you're staying in, or the bigger place, that the bigger your city and town, and maybe in the country, because as it is now that the women are voting much, the strength is much more than the males. So we are we are getting our power, and we have to utilize it rightly and not misuse this power and judgment in any form. So today, with this theme of empowering every woman, equality, progress, and inclusion, thank you so much, and I wish you all a very, very happy Women's Day today. And thank you, and over to Ankana. If you have any questions, we can take, because I think Dr. Meenu was caught up in an emergency, so she would not be joining. But I think Dr. Lakshmi could deliver everything very nicely. She has made us understand. So any questions we can again take, otherwise we call it a day and we say goodbye.
Thank you so much, doctors, for the major deliberation. I'm sure our audience got to know so many things in this discussion. Ma'am, I can see a few questions from our audience doctors. With
Yeah.
your permission, can I put them across?
Yeah.
Okay. So the first question is, when should a testicular biopsy be recommended in cases of azoospermia?
Okay. So actually these days we are not doing testicular biopsies much, but because we have so many hormonal tests, we have ultrasounds. So by those and by history, we can all come to a conclusion that is why the azoospermia is there. But yes, there are, when there is complete oats, that means azoospermia, teratozoospermia, and we wish to see if there is somewhere some spermatogenesis is occurring in those cases, whether we can utilize that particular sort of process in doing our IVF. Because if there is a spermatogenesis, we can take a biopsy from that particular area, or we can extract sperm from there, freeze them, or when we can use them during IVF, ICSI. So that is one. Plus, to diagnose the condition, we can do.
Yes. So in cases of obstructive azoospermias, we go for testicular biopsies, right? And then we take out those sperms, and then we can use them for the ICSI, as Dr. Jyoti has said.
Okay. What is the recommended timeline by trying IUI before moving to IVF?
Yeah, Dr. Lakshmi can take that.
Yes. So timeline, as we had discussed, 3 to 4 cycles of IUI is what we can go for, and it is a good try. If we give a good 3 to 4 cycles of IUI, then we say that we have tried enough of IUI, and if that doesn't work, then we go for the IVF. So I think 3 to 4 cycles of IUI is good enough.
Last question of today's session, that is, when should a myomectomy be considered before IVF in women with fibroids?
Oh, they are very brilliant questions. Our viewers are, I think, well read, and they are asking us such difficult questions and such good questions. So I think I'll take that. And myometry definitely depends on the size of the myoma and the position of the myoma, where the myoma is. If the size, if it is a subserosal, that means if it is outside towards the outer side of the uterus, if the myoma is more of subserosal, we do not need to do anything. If it is submucosal, that means it is inside the uterus, and if it is of at least more than 1 centimeter, more than 10 mm, it needs to be removed. Very small polyps, let's say 4, 5 mm, 7 mm, depends on whether they are there every time or they come off and on. Sometimes due to hormonal changes and due to excessive estrogen, we can get polyps, but they disappear. And if they are there all the time and they are a reason for infertility, once we've done a hysteroscopy and once we've documented that there is a polyp, at the same very time we can remove those polyps or small myomas. Now, if they are inside the uterine wall and if they are small size, let's say 2 to 3 or 4 centimeters, we do not need to do anything. If they are greater than 4 centimeters, people do say that they could affect fertility by affecting the myometrial contractility, and they also by releasing various cytokines, they could affect the fertility. So that if they are very large size inside the uterus, or if there are multiple myomas, then only we need to remove. Otherwise, there is no need to remove these big myomas. Now, I think these are the only things. If those myoma, another important thing is that if the myoma is touching the endometrium lining, if it is affecting the lining, if it is distorting the cavity, then they also need to be removed, even if they are small size.
Okay, that's all the questions we have received. Thank you
Yeah.
so much, ma'am, for your expert opinion that you have both have shared. And I'd also like to thank all the participating doctors for your continuous participation at our platform. Thank you once again, ma'am, for your valuable time and for being with us at our platform Mate Talks and sharing such valuable insights with us. With all your permission, can we just end the live here?
Yeah. Thank you so much.
Thank you.
Thank you. We would like to thank IJCP for giving Haryana ISAR this opportunity to come here and share our views and our experiences, our knowledge. And thank you, Ankana, for hosting us today. Thank you.
Thank you so much. Thank
Thank
you.
you, Dr. Lakshmi.
Thank you, Dr. Jyoti. Thank you for being a wonderful host.
Thank you.